In this mini lecture, we're going to cover peripheral nerve disorders. So neuropathies, Bell's palsy, trigeminal neuralgia, and shingles. These are very commonly seen in the clinic, so it's important to know something about them. So by definition, peripheral nerves include your cranial nerves, all the spinal nerves, and all the nerves that emerge from nerve plexuses, so everything outside the CNS. They carry both motor impulses, both somatic and autonomic, as well as sensory impulses. So they carry motor impulses out, sensory impulses in towards the CNS. So peripheral nerve disorders can cause motor symptoms, and typically that would be muscle weakness, maybe atrophy of muscles, impaired balance and coordination. They can have sensory symptoms, loss of sensation, so numbness, pain, tingling. Allodynia is sensation of pain to normally non-painful stimuli. So a patient with allodynia, if you just breathe or they feel wind on their skin, that they experience that as pain. Neuralgia just means a disorder of the nerve, and then neuritis is inflammation of the nerve. Autonomic symptoms would include loss of bladder control, abnormal blood pressure, heart rate, lack of sweating, etc. So all of these could potentially manifest as peripheral nerve disorders. So again, by definition, neuralgia is pain in the nerve. So like trigeminal neuralgia, sciatica, post-herpetic neuralgia. Neuritis means actual inflammation of the nerve. And a neuritis and neuralgia might actually go together, but by definition, the nerve would have to be inflamed in neuritis. And then neuropathy is a disease of the nerve itself. So peripheral neuropathies, nerve diseases, would include mononeuropathies, and that's a condition that affects a single nerve, or polyneuropathies, that affects multiple nerves, usually affects the long nerves and in what we call glove and stocking numbness. So you feel like there's a sensory paresthesia on the hands, almost like you're wearing gloves, or on the feet. Weakness in the muscles in the hands and the legs, etc., and then maybe impairment of balance because of loss of sensation. And then autonomic neuropathies would affect mostly the bladder, the cardiovascular system, digestive, or the genital organs. So the most common cause of neuropathy for mononeuropathy would be nerve entrapment. So the classic here would be carpal tunnel syndrome, and that's compression of the median nerve in the wrist, and that causes the typical sensory changes that people experience with that. That has a high correlation with endocrine issues like hypothyroidism that's often undiagnosed, so that should be investigated. Bell's palsy, facial weakness, another example of a mononeuropathy. This is affecting cranial nerve number 7. Remember, that innervates the major motor nerve to the facial muscles. Trigeminal neuralgia, cranial nerve number 5. That's going to be a sensory neuropathy, so we get pain in the face. And then shingles. This is going to affect usually a single sensory nerve affecting a single dermatome. And so the herpes virus infects that nerve and it's isolated to the dermatome. So those would be examples of mononeuropathy. Polyneuropathy would be things like post-infectively Guillain-Barré, which we already talked about. That's where you get a demyelinating disease of the peripheral nerves, and it affects usually more than one nerve. Chronic illnesses like diabetes, nutrient deficiencies, especially B12 is a big one. And then different toxins, alcohol, medications might induce polyneuropathy. Classically, peripheral neuropathy, we'll talk about that here. That's from uncontrolled diabetes. It could also be from chemotherapy, get a neuropathy from that, and so forth. And a lot of patients will actually come for acupuncture specifically for neuropathies because there's little the biomedical community can actually do for them. And then for advanced neuropathy, again, advanced diabetes, autonomic neuropathy, diabetes can actually affect not just the sensory system, so causing the glove and stocking paresthesias, but also can affect your autonomic function, bowel and bladder control, autonomic control of blood pressure, and so forth. So let's look at a couple of these. Bell's palsy, let's talk about that here first. This is pretty common. Hemifacial weakness, paralysis of muscles innervated by the 7th cranial nerve, the facial nerve, and it's due to swelling of the nerve. And we think it's probably due to a virus, maybe herpes simplex or another virus. Usually Bell's palsy is preceded by an upper respiratory tract infection. But usually there's acute onset of unilateral facial weakness or paralysis. It affects the upper and lower face. The eyelids may droop, and that exposes the cornea. and that could be a big problem. So I'll talk about that in the treatment here in a second. The corner of the mouth droops, and there might be possibly altered taste on the side of the tongue. Remember that the facial nerve also has a sensory division, and that innervates the anterior tongue and your taste receptors there. But no pain. So remember, the facial nerve is motor to the face and only sensory to the tongue, to the taste receptors, so there's no pain involved in Bell's palsy. Again, the cause is often unknown, but we think maybe viral. The prognosis is very good. Most, up to 80% of patients usually recover within a few weeks to months. Some go on, though, and have persistent dysfunction of the facial nerve, and so they have persistent eyelid drooping or facial muscle drooping. The diagnosis is clinical. I should mention one etiology could be Lyme disease, and that should be considered in Lyme endemic areas. We do know that Lyme disease can cause Bell's palsy. And then EMG testing and MRI could be helpful if there's no resolution over time. So that would just be for further workup. Usually no treatment is required. Typically the biomedical approach is to maybe give a short pulse of prednisone, but not if Lyme is suspected. That would suppress the immune system, making Lyme worse. And then acyclovir, which is an anti-herpes medication if herpes virus is suspected. So that's often a common combo. You might see patients taking prednisone with acyclovir with Bell's palsy, at least in the early stages. Sometimes an eye patch might be needed at night, and that is to prevent corneal abrasion due to the eyelid drooping. And then potentially decompression of the cranial nerve 7. And that's usually only in severe cases that maybe are worsening over time, and then maybe eyelid surgery to work with the eyelid. So that would be the general approach to Bell's palsy. A couple more common neuropathies. Trigeminal neuralgia TGN, also known as tic-douloureux. This is severely painful. So remember, trigeminal nerve is sensory to the face. So you get severe neuralgia of the trigeminal nerve, brief attacks of severe stabbing electrical facial pain. Some say it's actually one of the most painful pain conditions out there. Radiates down the face from the area in front of the ear. Light touch, shaving, washing cold may bring on an attack. It's recurrent, so the attacks kind of get better for a while, then they worsen again. And there can be gaps of weeks between the attacks. And most patients have a relapsing remitting course. It gets better, then it gets worse, gets better, worse, etc. No motor or sensory paralysis. So the motor system, again, the trigeminal does innervate the motor nerve to the masseter muscle for chewing, but there's no deficit there. And then it predominantly affects the elderly, so it's the incidence increases with age, and the cause here is unknown. Sometimes there can be structural irritation to the trigeminal nerve, such as a tumor or an aneurysm. So in some cases, we actually do an MRI just to confirm there's nothing compressing the nerve, making it worse. And so that's sometimes part of the initial workup to be sure there's not something that's actually treatable there. So usually the MRI is used to look for tumors that might be compressing CN5. And then the treatment is usually using anti-seizure meds because the pain medications usually are not effective. Remember, anti-seizure meds just pretty much stop or they slow down the electrical activity in the nerves, and that would include in the trigeminal sensory nerve, slow down that activity. So carbamazepine, phenytoin, we saw these with the epilepsy section, lamotrigine, gabapentin, and baclofen are all potential medications there. Decompression of cranial nerve 5 and then injection of alcohol into the nerve can actually paralyze and basically permanently numb the nerve. So that's sort of a last resort for some people. So that is trigeminal neuralgia. And then there is Varicella zoster, shingles. This is caused by the chickenpox virus, and this is a late consequence of a chickenpox virus infection. Chickenpox virus is a herpes virus. So along with herpes simplex, along with Epstein-Barr, cytomegalovirus, varicella zoster is in the herpes virus family. And herpes viruses infect nerves. They affect neurons. And so what happens is that you get a chickenpox infection early in life. The thought then is that the chickenpox virus lives dormantly in one of your sensory nerve ganglia, and then at some point later in life it erupts through that ganglia and it affects a specific dermatome on the skin. So the initial phase is the viral particles actually breaking out of the nerve. We get painful red blistered skin, and that usually crusts over after a couple of days. It's still very contagious at this stage, and a person can actually spread chickenpox at that time. The lesions, again, are going to be located on a single or maybe two dermatomes on usually one side of the body, so it should not be bilateral. That'd be very, very rare. And the RAS usually itself resolves within a week. But what can happen in some people, about 10%, is they can develop what's called post-herpetic neuralgia. So the rash goes away, but that area of that dermatome is extremely sensitive and tender. And so the skin remains very sensitive and painful, and that can last for months to years. So I saw a patient not too long ago that has post-herpetic neuralgia for the past 5 years, and nothing has really seemed to improve it. We think that the cause of this is when natural immunity or maybe stress hormones or something that suppress your immune system is too active. But whatever reason, the chickenpox virus breaks out and the immune system no longer keeps it in check within that cell body, and it breaks out through that sensory neuron. It can affect the facial dermatome, and this is most concerning when it's in the trigeminal nerve, and it affects CN5. So shingles on the face, especially around the eye, we are especially concerned about because that can cause blindness. So that's an immediate referral usually, and what they do is high-dose steroids to try to knock that infection down. The diagnosis is clinical usually. The treatment is going to be pain relief typically, and that's again through anti-seizure meds or amitriptyline, which is a tricyclic antidepressant. That's commonly used for, you will find that's used for neuralgic pains. And we'll talk about that one in the psych med section. And then antivirals like acyclovir if we suspect, the herpes, this is a herpes virus. So if we catch this in the early stages, usually within the first couple of days that the patient presents, acyclovir seems to be able to reduce the duration of the infection and potentially to reduce the incidence of post-herpetic neuralgia. So I'm just talking about the biomedical approaches here. Of course, we would think about the therapeutic order 1 through 3 as well to go along with this. All right, so we can talk a lot more about peripheral nerve disorders, but I think that kind of covers some of the big ones that you'll probably experience. And that will wrap it up for this section on the neurological disorders.